I am Richard Broth. I go by Richie. No Dr. Broth in this, we're all colleagues. And you can stop me at any time if you have a question. I was told I have 15 minutes, so I'm probably going to speak a little quickly, but I want to get the information out to you. The purpose of the talk is to kind of pique your interest in understanding preterm labor through the eyes of someone who deals with it really on a regular basis. Family practice is a very wide scope. So I know that some of you may be more focused on women's health specifically and do a lot of it. Some may not. Some may be in a more rural area. Some may be in a more urban area. So I'm going to kind of explain it in that capacity so that you understand what we do and what we do with this and how fibronectin kind of is part of the armamentarium of what we use. So without further ado, let's go. I'd like to thank the Hologic people for bringing me over here to talk to you guys, by the way. And this is completely full of commercial bias. So without any doubt, you are going to hear a skewed view, but I will prove to you at the end that it's really not a skewed view. Okay, so I guess I can look over here. Okay, so we have the reality of preterm labor. So 50% of patients hospitalized for preterm labor, at least, it's probably even more, give birth at term, number one. And then less than 10 or fewer than 10% of women with a clinical diagnosis of preterm labor actually give birth within 7 days. So the most, I guess, common scenario is a patient is at home, they're 27 weeks pregnant, they feel some pelvic pressure, maybe some cramping, they run to the emergency room and get evaluated. Now that emergency room could be a university hospital, that emergency room could be a veterinary hospital because there's no one else close by. So we have kind of the range of where the patients are going to go because they're concerned. Okay? And so we have a bunch of different options of how to evaluate the patient. And again, when we're early in our career and we think that, that we know everything, so the answer is I can evaluate that patient. I for sure know how to evaluate. I'm a perinatologist, for God's sake. I can walk in, take a look, and know they are in preterm labor. I have 10 years of experience, 20 years of experience. Don't tell me what I need to do. I'm going to go in and evaluate. So there's that clinical experience. There's the medical history, the tochometry, and then the physical exam actually of evaluating how effaced, how dilated the patient is. Okay, there's the vaginal ultrasound that can be done, which is really a cervical length evaluation. And then there are biomarkers, which is the fibronectin. So again, 3 options for that assessment: clinical assessment, cervical length, and biomarkers. So there are different options that we have when someone comes in preterm labor. And the question is, does it matter if we know exactly when that patient is going to deliver, even if we know that they're going to deliver? Does it matter whether they deliver within 7 days or not? So let's go back to the medical history. There are certain things that we know, and they're listed here. I'm not going to go through them. But they're listed up here of things that we know that have a higher incidence of preterm birth. So again, African American ethnicity, low socioeconomic status, maternal stress, which again can't really be evaluated from one person to another, and then clinical factors, including a prior history of spontaneous preterm delivery. So with those factors that are up there, you ask the patient, we see them, they fall into a specific category, and we see, does that fall into something that makes us a little bit nervous? But remember, at least 50% of patients who come in with concerns for preterm labor aren't going to be in preterm labor. And people with these clinical criteria that you're most worried about, those patients actually aren't going to necessarily deliver. At least 80% of them aren't going to go into preterm labor the next time around. It may even be more. Okay, so what about cervical dilation and effacement? Okay, so you can see, if you look at contractions and vaginal bleeding on the left, and contraction frequency on the right, you can see that you have an increased relative risk of delivery. But again, 1.5 for contractions, that's really almost nothing. And maybe 3 times if there's some vaginal bleeding maybe associated with sort of an early bloody show. And then the frequency, if you're having more than 8 contractions per hour, about 9% predictive of whether they're going to deliver within 7 days. Definitely not something that we're hanging our hats on for that. Cervical length assessments. You can see on the left-hand side, this is the cervix, here's the baby. That's the vagina over here. There's the ultrasound version of that, so you can see a long cervix over here. Over here is a short cervix, and this is what they call the funnel, which leads down. The best way, the way I describe it to patients, is it looks like a zipper is opening. So if the zipper is opening from left to right, you can basically see the cervix opening like this. So even though on a digital exam, you may appreciate a long cervix, the actuality is that it could be that cervix on the right-hand side, which shows a much shorter actual cervical length. So when we do the exam, which again, going back to, oh, I've got all the experience, you can't figure that out with your fingers. Okay, there's just no way to do it. So you need the transvaginal ultrasound. What is a short cervix? There's controversy as to what that is. Basically, the best way to think about it is if it's less than 1.5 centimeters, it's short. If it's greater than 2.5, it's not short. And between 1.5 and 2.5 is controversial. So the biomarker, specifically fibronectin. Now, the reason I say it's full of commercial bias is because all I'm going to be talking about is fibronectin. The problem is fibronectin has no competitors. Okay, so really I'm not here to prove to you that fibronectin is better than test B. Okay, what I'm here to prove to you is whether or not fibronectin is a reasonable test to use, or you think it's bunk and you don't need to use it at all. Okay, so if you come out of here feeling 50.01% confident that fibronectin works, then you're going to use it because there's no reason not to. If you feel that what I'm saying is a bunch of malarkey, then we're not going to use it. But at the end of the day, it's not fibronectin versus, option B. There's no option B when it comes to this test. I'll give you a little bit of background here. When I first started using fibronectin, I totally did not believe in fibronectin. I was forced to use it by the practice that I went to. Dr. Ron Labrizzi, who is a great mentor of mine, who has since retired, he said to me, this is what we do in the practice, this is what you're going to do. I said, whatever. And he said, use me as your safety net. He said, when you talk to patients and you explain to them, and I'll explain how I use it, but he said, when you talk to patients, this is how what I want you to tell them. And if they disagree, call me in, I'll talk to them. But he said, trust me on this. Within a couple of months of doing this, using me as the safety net, you will believe it, okay? And I'll tell you my numbers at the end of the talk. And if I forget, someone remind me, but I'll tell you kind of my experience with it, which is anecdotal from my perspective, but suffice it to say, I can remember every failure that I've had, and I've been doing this for 15 years, okay? So there are two approaches when you look at fibronectin use. One is the first scenario that I gave you, a patient that shows up into the emergency room because they have pelvic pressure. The other is an asymptomatic woman who comes to the office, and they're really very separate. If you are following patients with a history of preterm labor, if you are following patients who have, let's say, a history of a leap or some other risk factor that puts them at risk from the slide before, that puts them at risk for preterm labor, then you may be following cervical lengths. My guess is that in a family practice setting, unless you're really rural, most family practitioners are not doing serial cervical lengths. Is that fair to assume? Okay. It's not fair to assume? You do them? Awesome. You're the only one who said yes, so I'm going to say this. Okay, great. So for those who do it on a regular basis, the outpatient model is really, and I'll talk about both of them, but the outpatient model is what we do as well. The inpatient model is the person who comes into the emergency room complaining of the pelvic pressure. The difference has to do with, in other words, the predictability is going to be the same, but the difference is A, in the office when you actually decide to send it, and B, in the emergency setting, usually if there is a machine there, you're going to get the results back much quicker versus in the office where you have to send it to the lab. Those are really the differences. In terms of the FDA approval, the symptomatic patient, you can really do the test between 24 and 34 plus weeks, whereas the asymptomatic, you can theoretically start a little bit earlier at 22, 23 weeks up to about 32 weeks, and that again is FDA approval. Fibronectin is a mesh. It's the area over here between the maternal and the fetal membrane, and in essence, if there is uterine activity, that glue that's holding the fetal membrane and maternal membrane together is going to shed into the posterior fornix, and when you take the swab and you put it in there, it's going to collect, and then you're going to send it off. And really, this is almost like a pass-fail test. Either it's present or it's absent, and that's how we're going to use the test. So first of all, we're going to just discuss, and I apologize for the basic nature of this, but there's positive predictive value and negative predictive value. Positive predictive value basically means what is the likelihood or a rule-in test, what is the likelihood that if I do this test and it turns positive, that the patient will have the result that turned positive? The rule-out test is what is the likelihood that it won't happen? So with fibronectin, the question is this patient going to deliver if the fibronectin is positive? That's the positive predictive value. And the negative predictive value is if it is negative, what is the likelihood that the patient won't deliver? Okay, and the mindset that one has to be in for the fibronectin test is the rule out, meaning what is the likelihood that the patient will not deliver? We don't look at the positive predictive value as the key. It's the secondary, and I'll show you some data that it's good, but the negative predictive value is really the way to use this test, and that's the best. We're going to look at some strengths and weaknesses of all the three aspects that we looked at. So for clinical assessment, there's no equipment required and 24/7. You can evaluate the patient as long as you're there, but it's subjective, not standardized, and you really can't tell, even, like I said, with all the experience in the world. With the cervical length, the strengths is that the longer the cervix is, the more correlative it is with a later delivery. The shorter it is, the more correlative it is with an earlier delivery. And you can actually visualize the cervix, and as we said, the digital exam is going to be potentially much different than the cervical length exam. However, the weakness is what are the cutoffs for a positive or negative? What is the likelihood that you have the machinery at your disposal to do it at the time? And even with well-trained, using Clear or any of the modalities out there to certify, it's still not, at least 30% may be assessed incorrectly. You have to, and the best way to think about it, I'm going to use a little visual aid, is if this is the cervix, and this is the transvaginal ultrasound, you come in like this, so you're going to get the cervical length. However, if you come in at a little bit of an angle, you're going to think you have the cervical length, but you're cutting it like this. When I'm evaluating that as a picture and I'm not there in real time, I could be, I put a lot of faith and a lot of pressure on my sonographers to be able to give me that image. So generally, if I'm available in the office, I go in and watch the ultrasound because I don't want to be fooled. Because you can see sometimes a funnel when there isn't a funnel. You can see sometimes if the probe is placed too far, when the funnel is over here, if you push it in and make it close, it doesn't look as bad. So I tend to go into almost all vaginal ultrasound. But again, what is the likelihood that you're going to be able to do that at 3 o'clock in the morning in the emergency room? Number one. And number two, what is likely you'll be able to do that if you're running a busy practice? So again, I have the luxury because this is all I do. When you guys are running from a pediatric to a geriatric to a pregnant woman, you don't necessarily have that ability to do so. Okay, and then the FFN, the strengths, it's objective. It has a high negative predictive value. Okay, which again, what does that mean? That means that a negative test means that there will be less than a 1% chance that patient delivers within 7 days of the exam. It can be used on singleton and twin pregnancies. You can get a result within 30 minutes if you have the machinery to be able to. The sample is collected for free. Again, this is a real important point. One of the greatest things that this company did, actually it was the prior company, is they said that we're not charging you for the kit. So you get the kits, they'll send you just call them up, boom, and a big box of FFN comes in. You can take those kits. We don't really do this, but they come with a nice little swab. If you need a swab for something else, they're not going to know, right? But at the end of the day, it comes for free. So there's no harm, and when I tell you how I use it, you're going to see that I use many more kits than I send. And so therefore, if the obstacle is the kit, it's not because it's free. Okay? And then the sample is valid even, let's just say it's Friday afternoon, patient comes in and you go home for the weekend and then you go in on Monday morning and the patient didn't call you over the weekend and you called up for the results and they say we don't have any results in the lab and you're like wondering what's going on. You show up and it's sitting on the desk, someone forgot to put it in the lab box. You still have time to send it in. You don't have to call the patient back to do it again. So there's a lot of flexibility and strengths of that. Weakness, it has to be collected prior to a digital exam or any type of vaginal use. So if someone is placing vaginal medication, if someone is using other materials vaginally, then, then you could get a false positive result. So generally we ask the patient, I used to ask them if they've had sexual activity, but again, some people do things that are, not sexual in nature and would say no. So what I usually ask them beforehand is I say, has there been anything in the vagina in the last 12 hours? If they say no, then I go ahead and do it. Even if, let's say, they say 11 hours, I'll do the test, and with a negative value, it is reliable. With a positive value, I potentially would have them come back and repeat the test because it's within that 12 hours. There is some data that even 6 hours is okay, but as a general rule, we started out at 24 many years ago. We brought it down to 12, and like I said, some people are pushing the envelope to 6, which basically means that you're more interested in getting the result, and if it's negative, relying on it, but if it's positive, saying, and I always tell the patient, I said, if it's positive, we're not going to be so worried about it. And truthfully, it's not much different than even if I knew that they had 24 hours without any vaginal involvement, because at the end of the day, the positive predictive value, as I stated, is far lower than the negative predictive value is good. So the positive predictive value, although it's the best that we have compared to other modalities, it's still not great. So if it's positive, the patient shouldn't be like, oh my God, I'm delivering tomorrow. And so therefore, if I repeat it again because maybe it was a false positive, and then I give them that caveat, and they'll just come back and do it again. If you look at the data, you can say the negative predictive value for within 7 days is 99.5%, 14 days 99.2%, and less than 37 weeks, almost 85%, which means that if a random, and there's been studies that looked at this as well, if just every patient that comes in, for those who do OB in their office, who do cervical length in their office, or anyone who does OB, a patient comes in, you do a quick swab at, 28 weeks, they just show up, they live 3 hours away, and they have a history of delivering at 35 weeks. So you have a little bit, it's not someone you're seeing all the time. You do it and it's negative, they have an 85% chance that they're not going to deliver before 37 weeks just with that spot test. Okay, from a positive predictive value, you can see the likelihood of delivery within 7 days is like 12%, 14 days is 16%, less than 37 weeks is 44%. So really not something that we're like, betting the house on when it comes back positive, which actually works out really well, because what you're really worried about is sending someone home and having them deliver. So I will tell you in 15 years, it's happened to me 3 times, okay? And I remember each patient. One of them, I put in there because it doesn't change my stats and it still looks okay, but at the end of the day, I think that it wasn't my patient, I'm not sure it was done right, and she was already banging out contractions, may have already been 3 centimeters dilated, but the doc didn't examine her, and it was a twin. But that being said, I'll take credit for that one as well. 3, and I can tell you in 15 years, I've done thousands of these tests, okay? And not only that, but I sort of have a rule, which is that the fibronectin doesn't know what the cervical length is. I'll show you data that show that cervical length and fibronectin together are better than each one individually, but the fibronectin does not care what the cervical length is. When you look at certain protocols that have been established, those protocols usually have a range. They say, okay, if it's like shorter than 1.5, then you're automatically treating. If it's greater than this, you're automatically not treating. And they narrow the range of fibronectin significantly. I don't believe that. I believe that if you have a cervix that's 5 millimeters long with a negative fibronectin, I'm not treating. And like I said, I've had 3 failures in 15 or more years. Okay, so again, this is inclusion of the fibronectin, improves the predictive capacity. So you can see the fibronectin is the one on the left, cervical dilation and contractions. And you can see the positive predictive value much higher if you include it, and you put them all together and it increases it significantly more. Why do we care, right? Why do we care whether or not the patient is going to deliver? Well, obviously we need to have everything in place if that patient, and it matters because there's a difference between a preterm labor or preterm delivery at 36.5 weeks, which goes down as a preterm labor and delivery, or a preterm labor and delivery at 24.5 weeks. And especially when we're talking about the left end of viability, 22.5. I mean, at Holy Cross Hospital here in Silver Spring, we're giving steroids at 22 and 6. They're intervening at 23 weeks. Their survival statistics, I saw the wince, I got it. Yeah, their survival statistics are like 30% at that point, which is, I mean, it's insane. I tell people when I counsel and residents that come through, when I was a resident, it wasn't that long ago, the age of viability, the cusp of viability was between 26 and 28 weeks. And so we're like saving babies that are a pound. Now, again, all of us in this room know that if that were us, we may not be we may go home and deliver at home rather than be in the hospital and take intervention. And I get that. But at the end of the day, there are babies that survive and thrive that are born at the cusp of viability. So it's important, but if they're born in the middle of rural America, then that baby is going to have to be transported if the patients want. That's going to be much more difficult. And so to me, the reason to know and be able to understand and assess the potential for preterm delivery is for optimal intervention. And again, corticosteroids, magnesium sulfate, tocolytic therapy, and hospitalization and or transport. Really, the transport side of it, I think, pertains to many people within the family practice realm. Because again, if you're 2 hours from the closest hospital, imagine the scenario, and this happened to me as a resident and beyond, where a hospital 2 hours away gives a call and they say, patient's banging out contractions, they're 25 weeks, everyone's nervous, they want to send the patient to us. So great, send the patient. The patient gets sent to me. By the time they get to me, the contractions are spaced out, the cervix is nice and long, we do a transvaginal ultrasound, it's 3 centimeters, we do a little hydration, and then I keep them overnight so that it doesn't feel bad sending them home for 2 hours, or calling the relative to drive now for 2 hours because they were transported by ambulance in order to get to me, and it looks kind of silly. Now, granted, they understand because they were the ones who initiated that visit, but at the end of the day, imagine if we did a fibronectin, it came back in 30 minutes as negative, or an hour as negative, and now you call up and you say, hey, I know she's banging out contractions, but Broth said that he's had 3 failures in 15 years. This isn't going to be the 4th one because, as my mentor said to me, I'm your safety net now. I'm telling you that if you trust, then this is the safety net. Now you're going to say, you know what? I think I can wait another 1 or 2 hours, do some hydration, see what happens, so I don't have to send her for 2 hours so that she's going to turn around and have to take a bus back to get home. So that's that. Tocolytic therapy, again, no therapy has any lack of side effect, and so we don't want to give anything if we don't have to. How about steroids? We have 2 potential times for steroids, right? The first time and the second time. And so if you shoot the bullet first, then you're stuck with one more time. Patient comes in at 23 and a half weeks, and you think they're going to deliver and they want everything done, you're going to give the steroids, right? But all of a sudden, 2 hours later they stop. Now or 12 hours later they stop. You've given steroids, and now you've used that one of two opportunities that you have for steroids. Okay, benefit of antenatal corticosteroids, again, they're up there, but everything from NICU admissions to neonatal death, respiratory distress obviously is the main one, and then infection, IVH, and necrotizing enterocolitis. There's a 5-time increased likelihood of baby requiring intubation if the steroids were given beyond 7 days from delivery. And if you look, this is a really interesting study. Now, granted, it's 10 years old, and I haven't seen one that has taken this one over, but you can see 1.7% were questionably appropriate, 34% were suboptimal timing, and only 23% were optimally timed. Okay, and these were in the absence of fibronectin. So at the end of the day, we can do a lot better by giving steroids in a more optimal fashion in order to prevent the sequelae of not having steroids. Okay. Yeah. That's for babies, if you don't give steroids, steroids help prevent those complications. I apologize. This is my favorite slide of the whole thing. If there's one slide that I want you to remember, this is it. So this is the number of patients needed to treat in order to prevent 1 case of respiratory distress in the newborn, okay? And so you can see if the test is negative, so someone does the test but doesn't believe the test, which I discourage 100%. Either you believe it or you don't believe it. Don't do it. Get a negative test and treat anyway. 99% of the time. Again, I've had 3 failures. But 99% of the time, I would tell you, if you do the test, then rely on the test. But if it's negative, you have to treat over 500 patients to prevent 1 case of RDS. If you just don't believe it, you just use your clinical assessment, maybe a cervical length, etc. Make your own clinical decision, and you give it, it's about 1 in a little over 100. And if the test is positive, it's 1 in 17. So even though the positive predictive value is not great, it's still, you can see, an FFN test positive, it's 1 in 17 that you're going to be helping. So that's a far cry from 1 in 509. When I was a resident, there was a shortage of beta-methasone. There was, I think, some type of bacteria got into the mix. And so they had to throw out bajillions, I don't even know how many that is, but they threw out a bunch of betamethasone. So every single betamethasone that we had really had to be accounted for. At that time, we didn't really have fibronectin because I'm that old. But with this, you clearly can hone down. So I sort of treat everything as if there's a shortage of betamethasone with plus minus. I mean, obviously clinical acumen comes into play, but again, the more objective data one has to be able to utilize, the better off the test is. And then that goes back to the beginning, what I said is, again, we're not comparing fibronectin to any other test. The question is, does this modality help you make a decision that better helps your patient? And if the answer is yes, if I can convince you that the answer is yes, then it's just something else that you do and can help you make that decision even easier. So if you look at this, they did a study and showed with 23,000 patients with preterm labor, 24% of them were admitted and 76% were discharged home. 80% of those delivered greater than 3 days later, and 20% of those that were discharged home delivered within 3 days. And again, 3% had FFN only, 1% had FFN, 18% had transvaginal ultrasound, and 78% had no other modality except for clinical assessment. Again, this just goes to show that as great as we think we are from a clinical perspective, I think different modalities can help us make those decisions. Okay, so critical care opportunities were missed due to low fibronectin utilization. And again, also transvaginal ultrasound utilization. Okay, so what about collection? So we already talked about whom to collect on and how do we collect. So I'm going to present something that's a little controversial, so I apologize but the speculum examination is what the FDA approved. There was a study that came out many, many years ago showing that you can do it blindly and be just as good. Again, the same Dr. Labrizi said that if you're practicing OBGYN and you can't find the posterior fornix blindly, you shouldn't be practicing OBGYN. So at the end of the day, you take the swab, you part the labia, you follow the posterior vaginal wall all the way down to the end where it stops, and again, you have an appreciation of how deep it should be. If it only goes in about 1.5 inches, you're probably stuck on a ridge, and then you just have to play around with it a little bit. You get it into the posterior fornix, you keep it there for about 30 seconds, and then you take it out, you crack it off into the buffer, you kind of mix it up a little bit with the top on it, and then you can send it to the lab. So again, it can be done if you're doing a spec exam anyway. It can be done because then you'll see where it is. But in reality, you don't need that. And I can't remember the last time I did it with a speculum exam because I go in, I'm doing a transvaginal ultrasound. So while they're there, right before the transvaginal ultrasound, I do the swab and then take that out, and then I place the transvaginal ultrasound unless the patient wants to assist in placing the swab. We already talked about the collection window. Okay, so digital cervical exam. You want to do it before you do that, before you collect your cultures, before you do a vaginal probe. Again, anything that you're doing that is going to change the environment of the posterior fornix, you want to do the fibronectin beforehand. Okay, if the patient has any bleeding, so what happens? The patient says, I bled, I'm spotting. I always do it anyway. If it comes out and it's red and it's saturated, you've got more problems to worry about than preterm labor right now, so you'd have to evaluate that, and I would recommend doing a speculum at that point. But if it comes out with just a little spot on it, it's still okay. I sort of use if like 80% is covered with spotting, or if it looks really like it's a bleed, then I won't send it. If the patient is 3 centimeters dilated or greater, then you treat as preterm labor. And then again, abruption, previa, all that kind of stuff. Again, I think you can be gentle about it. Rupture of membranes is an interesting one because it actually, a positive result can confirm ruptured membranes in many cases, but people aren't using it like that, and it's not FDA approved, so I didn't really say it. Okay, again, I think easy things. We talked about the 24-hour or 12-hour rule, etc. Okay, so SFM recommendations from February basically say they're optimally effective for steroids when administered within 7 days. We do allow up to 14 days. We don't repeat the course of steroids within that, but definitely within 7 days is the measure that we're looking for. And then a perinatal quality metric measured the rate of antenatal corticosteroid administration at any time. And again, it incentivized providers to use steroids liberally, and they got everyone to start thinking about, the whole purpose was to get people to start thinking about giving steroids, and they got it to the point where like 97% of patients that were in a predicament to get steroids got the steroids that they needed to get. And again, this is honing it into getting it at the appropriate time. The summation is, if a patient is in labor, you want to take care of them, but if a patient is not in labor, you want to send them home. We all round on patients in the hospital. The more patients that are there, the longer you're in the hospital. That's a really easy approach, right? If you can send them home and they come back to your office, that's great. If they have to be in the hospital, then they have to be in the hospital. I don't know if I did in 15 minutes, but I appreciate your attention.